Yeah, I feel like I don't need to do much of an introduction, but so proud to be able to introduce Dr. Databoy and Dr. Carreras, who are representing also Dr. Molina and Anita, who are not here with us today because they have moved on, having graduated residency just 2 weeks ago. So very proud of this whole team. I think Farah, you and Anita and Mel reached out about this when you were second-year residents, and really pumped to see all of the work and effort and leadership you've put into it. So, oh, and I will say one last thing is I was on some of the United Against Racism presentations today, and your work was cited as sort of championing how we need to think about restraints with an equitable lens. So the press is wide across the MGB. So I'll pass it to you guys.
Thank you so much for that. And just to start out, I'd like to thank the Office of Ideas. As Dr. Marsh mentioned, we had started noticing these disparities as second years and started talking about it. But and I was telling Josie this today as well. I think the Office of Ideas and the support you guys gave us monetarily, but also administratively, was what actually helped propel this. And without it, we've been talking about it for a long time, but this was the catalyst that made this possible. So thank you guys so much. I will start off by sharing my screen. This is hard to follow because this is a PowerPoint, so it's not as exciting as the radio personalities. You guys can all see my screen. I don't know why it's ending here. So going back to this, our project was reducing bias in the de-escalation of emergency department patients. And this was led by myself, Anita, Melanie Molina, and Dr. Josie Carreras-Tata. So we, the background of this, and some of you guys are familiar with this work, focuses on our concern that patients of color were restrained more disproportionately, and whether that was chemical restraints or physical restraints. And this was something that we had noted in our clinical experiences, but we decided that we were going to go ahead and actually look at the data and then design a curriculum around reducing this trend. I don't know if you guys can hear me because it's very loud in my street. Hopefully they're leaving now.
I was just wondering what it was.
It's the garbage truck.
Honest. We can hear you though, to answer your question.
Great. So we started with looking at data, then we designed a curriculum, and then the last part of it was we actually piloted that curriculum. So I'll go over each of those components as we get along and what we found. The data analysis, we wanted to look at patients with mental health disorders and specifically younger patients. Our concern was that there is two populations we see in the ED. We have patients who are older with dementia, and they have different requirements in restraint use. And then there's also patients who are younger and might be there for trauma or psychiatric illnesses. And that's the population that we were focusing on. The concern being that Black men who were younger were disproportionately being restrained due to this perceived threat. So we decided that we were going to look at patients of color and specifically patients with who came to the ED in 2019. In 2020, all of our data was a little skewed. So we decided to go to 2019 and look at patients with the primary diagnosis of mental disorder. And that was the umbrella diagnosis, and that's the data we pulled. We found that there were 1,226 unique ED visits to the Brigham with 988 unique patients who were under the age of 65. And this is the breakdown of the patients by race. This is by sex. There's 48% female, 52% male, and then patients by race, we had about 51% white patients, 27% Black patients, and 5% Hispanic patients. And then this is largely representative of the patient population that we see at the Brigham, so this was not surprising. Our age distribution was, our mean age was 39 years. Our median age was about 37 years. And that's the patient population we were looking at. And we looked at patients who came to the ED with this umbrella diagnosis of mental disorder, whether that was bipolar disorder or suicidality or depression. And then we looked at the rates of restraint use, and this is physical restraint use in the ED, and this is per EPIC orders. And we actually found that 2.5% of Black patients under this group were restrained compared to 1.89%. This was not a significant difference. And so in some ways, with a very simple paired-T test, we were able to find that some of the concerns that we had were not bearing out. This was very preliminary data, and we need to do more work in getting controls in the picture because this is a very simple test, and preliminarily we found that there are no differences in terms of physical restraint use. We then looked at patients who were sectioned. And this was interesting. So patients who underwent a section 12, and that's patients who could not leave without were thought to be dangerous to themselves or somebody else, so they were not able to leave the ED on their own will, and so they were under Section 12. This patient population, 33.2% of Black patients under this diagnoses were placed under Section 12, whereas only 25.9% of white patients in the same category. And this was significantly different. So there is a difference. There's about an 8% difference in the patients who come into our ED who are Black, those are white, and Black patients are more likely to be sectioned. The next part of it was we looked at chemical restraint use. And so specifically, after much discussion, we decided to see that, to break this down by the medications that we use. And so chemical restraints, we considered Haldol and olanzapine. And for Haldol use, again, 6.25% of Black patients under this diagnosis received Haldol in the ED versus 6.8% of white patients, and this was not a significant difference. We looked at the same thing for olanzapine use, and here we did find a difference. So 2.5% of Black patients under this diagnosis received olanzapine in the ED, whereas only 0.4% of Black patients got olanzapine in the ED. Sorry, I'm going to say that again. 2.5% of Black patients and 0.4% of white patients. So there was a significant difference in the rates of olanzapine use in patients who come into the ED with mental disorder. And so some of this work we pursued in conjunction, and so we were simultaneously looking at the data and designing a curriculum. The next part of it was curriculum development, and this was to think about how we can train the teams that we have in the ED to better manage patients who have psychiatric illnesses or patients who are agitated for any number of reasons in the ED. And so the thought process being there is very little formal training, at least in the medical MD and resident curriculum, as well as there is some training in the nursing curriculum, but thinking through what are the ways that we can interdisciplinarily and collaboratively approach these patients so that we're all on the same page, and then we end up using fewer restraints in this population, and specifically targeting biases that we might have. The first part of the curriculum development was participant recruitment. So we recruited residents, faculty members, nurses, APPs, and this was the thought process being that we want the entire team that is typically at the bedside for a patient to train together, again, so that we can approach these patients in a collective way. We wanted to offer reimbursement for everybody's time. And so we decided that we would give participants $250 to partake in this 2-hour session. And we also wanted to make sure that this would help motivate people who don't necessarily are drawn to this field or not always at these meetings. And so we wanted to really reach beyond the usual circles of DEI and get to members of our teams who may not be exposed to this kind of work. And then we did 4 sessions. Each was 2 hours. They were held on April 19th, back to back, and on April 22nd. So this was just showing you a little bit about the participants and what it looked like. We did this at Stratus, and these images are meant to capture the fact that we had a diversity of people there from ESAs, PAs, residents, attendings, and nurses. And we had really great turnout, and we had really wonderful participation from every one of these groups. The didactic component consisted of, so the way this was structured is that we had everyone come into this room right here, and then we started with a didactic component. And here you can see Mel delivering this piece. And then this was followed by case-based learning, which I'll go over, and then a discussion, and then another case. So the didactic component, we spent a lot of time thinking through what we wanted to deliver as part of this curriculum. So there were things we drew from the American Association of Emergency Psychiatry. So in 2012, the American Association of Emergency Psychiatry came out with a de-escalation group, and they have these best practices that they recommend using when patients are agitated. And this was an algorithm that we have published and also presented in multiple meetings on kind of how to approach the agitated patient and how to do this in an unbiased way. And so this piece of it, where you have the best practices, that's on the right, if you can't see my cursor. That was done, that was adapted from the American Association of Emergency Psychiatry's recommendations. This is modified so that we could condense this into a handy mnemonic so that when folks are at the bedside and they are approaching this patient, they can quickly go through all the steps without having to look at something or refer to a resource. And so this is what we call the relaxes mnemonic, and this went over best practices. And then this was new. This is something that has not been done before, and I think this is really kind of the innovation that we are bringing to the table, and that was to perform a bias check. And so one of the components of our curriculum was to really emphasize self-checks, not other people's necessarily, but to do a self-check and the biases that we each bring to the table. And in doing so, we talked about race and the role of structural racism and bias on racial disparities that we see in healthcare, and then we presented some of the data that had been done prior to our work at Mass General. And so this was the 15-minute prelude to the case-based curriculum that we gave. The next part of it was the simulation curriculum, and this was really the fun part of it. We had 2 cases, and this was done at Stratus. I really love this picture because it's so reminiscent of how it is in the ED when we have a patient who has a psychiatric disorder and they're kind of lonely and in the back, and then everybody's like looking in on them like a fishbowl. So I felt like this really captures in simulation, it's high fidelity. And we had 2 standardized patients of color, and we conducted cases with both of them. One was a trauma-based case, the other one was a psych-based case. And so these were cases that we, as residents, had encountered. We adapted them along the way. Prior to the simulation day, we actually had a 2-hour training session with our SPs, and we went over each case in detail. They're actors, and so they wanted every detail ironed out, and that was a learning experience for us as well. But it was really wonderful. They gave us a lot of pointers on how to write out the cases, what it feels like to be somebody who's not in healthcare looking at these cases. And so it was mutual learning. We really learned from them, and we modified the cases so that we could optimize everyone's learning and also be culturally sensitive in the trainings that we were giving. And so these were our wonderful SPs, and that's me, Mel, and Jamal and Garrett, and it was just great. And after we did each case, we would come back to the room and debrief with the group, and then go back and do the second case. And then after the second case, we also debriefed. And I think this is where all the learning happened. It was less about the didactics. It was less about what we were delivering, but more about the discussions that were held between the different groups. So the residents were learning from the nurses, we were learning from the PAs, we were learning from the ESAs, and what each role group feels in these situations that are often like high pressure, and how do you manage people was some of the themes. And then the last part of it was the pilot. And here I'm going to hand it over to Josie, and she'll present the data that we found. We did two surveys, one before and then one after. Josie, take it over.
Yeah, so basically we had 27 participants total. We got 26 responses, which was probably because somebody either left early or arrived late and maybe wasn't able to complete the pre and post survey. But in general, you can see we had a pretty good mix. Our groups were mostly comprised by resident physicians and nurses. We did have some ESAs and PAs and NPs as well, and with attendings being the minority group. And some of the feedback that we heard was that attendings were trying to make, safe room for residents and other providers to participate in these, which we appreciated. In terms of race breakdown, over 2/3 of our participants were white or Caucasian, which probably reflects more the composition of our staff. The majority of the participants were female, and the majority were non-Hispanic or Latino. Oh, next slide. I was trying to advance the slides. There we go. So in terms of the pre-survey, we wanted to get a sense of where participants stood in terms of their perception of both racial bias and the use of restraints in the emergency department. On average, people agree with the fact that physical restraints are not the safest option to manage aggressive patients. And then that they also agreed with the fact that agitated patients just have an attempt at verbal de-escalation. They also agreed with the perception that patients in the ED can experience racial bias. There was also generally some agreement that agitated patients may be more likely to face racial bias. You can see that there's a little bit more ambiguity when you start saying things like patients of color are more likely to be physically restrained. And that's where I think a lot of participants appreciated when we shared the data in the didactics about the actual disparities that we're seeing in the use of restraints. Next slide. So comparing their level of confidence with doing certain tasks pre to post survey, you can see that overall participants reported an improvement in their level of confidence doing some of these things, including recognizing and addressing racial bias against an agitated patient, recognizing and checking their own racial biases, as well as general racial bias in the emergency department on behalf of other providers. And then they did also express more confidence in their ability to verbally de-escalate an agitated patient. And then in the post survey, we also wanted to check if this was a result of the simulation exercise and the debriefing exercise. So we asked basically the same question in different ways just to gauge a sense of how effective this was. So on average, people agree that they felt more comfortable communicating with agitated patients, with verbally de-escalating them, with recognizing racial biases against patients, with checking their own biases, and overall they felt better prepared to address racial discrimination. And I think a big part of this was from the debriefing exercise, because a lot of the themes that came out were how to confront colleagues and how to confront somebody who is either a peer versus how is it different when it's somebody you're supervising. So we were surprised to hear that attendings may sometimes be uncomfortable confronting residents about what they may perceive as discriminatory behavior, which you wouldn't think of, because as a resident, you think that attendings are sort of these powerful entities that you don't fear anything, right? But then, of course, we think more about residents in a position of less power confronting nurses or attendings about their behavior. And you can also see that there's a degree of discomfort there. So we talked about strategies on how to confront people in a non-aggressive way, in a professional way, and make it more about the patient and less about the individual. So that was a really good opportunity. We can go on the next slide, because we actually talk about the debriefing exercise. Yeah, so and you can see that people really liked the debriefing exercise. You can see that the scores in general are higher, and that they thought that it contributed to their learning while also allowing them to express their feelings. Because as you can imagine, these were very uncomfortable scenarios, and there was a pretty palpable tension in the room, which was deliberate. It was productive discomfort, and it was meant to push people to their edge, but not too much. And they thought that debriefing was overall valuable in helping them improve their clinical skills. So in terms of the qualitative feedback, I couldn't put it all here, but I just chose some representative quotes. What people liked the most was, as Farah mentioned, the interdisciplinary team discussion, just getting to know the perspective of other providers with different clinical roles. They thought they loved the sim actors, and in particular, they loved that the sim actors debriefed with us, and that was actually really cool. The sim patients, like sorry, the standardized patients, they're both Black men in the United States, and they were very candid about sharing their experiences, because although they may have not been in those clinical circumstances themselves, they have found themselves in situations where they have been discriminated against, and you could tell that people really, really appreciated getting to hear from the standardized patients. Having real life simulations. So, you can do all these didactics, but, nothing, obviously nothing is gonna beat having the actual experience with a real patient in the emergency department. But the sim experience actually was very well received, and it came pretty close to replicating the tension that happens in these cases in a way that a didactic during conference, say, wouldn't have been able to accomplish. And then the relaxes tips, people overall were very appreciative of the mnemonic and the de-escalation techniques that we discussed with them prior to completing the simulation cases. And of course, as I said, hearing feedback from the actors. In terms of areas of improvement, so people were asking for more de-escalation techniques, which could, we could modify our didactic to focus more on the actual techniques. Adding challenges and provoking comments from other team members. So basically, the very first time we tried this, the providers were actually really good at de-escalating the patient very quickly. So they actually, the standardized patients asked us to come in and add to the tension by pretending to be some off-service provider that made a racist comment in the room in front of the patient, and that escalated the tension. And that was actually suggested by the standardized patients. So for the subsequent scenarios, for the subsequent groups, we actually did that. So that's what that feedback is alluding to. And in general, like obviously people were much more tense after that, but it did, add to the tension. And of course, these were cases that were actually inspired from real cases, including the racist comments, unfortunately. So we didn't lose that element of reality that we were trying to replicate. They also said to make this requirement for all the ED staff prior to working in ops or the new psych ED, something to consider. Some people thought the slides were a little bit long. We can modify and tailor, as we go and do the different iterations of this curriculum. Setting more clear rules about the sim, because one of the scenarios was a trauma patient who were trying to undress, and that was the whole source of the escalation, that he didn't want to be undressed because he had an ankle monitor. And I'm pretty sure that on one of the groups, his pants came off. I mean, it's fine. He was fine with it, but that was not the intent of the scenario. So trying to clarify, what can we take off? What can't we? Because these are standardized patients, and these are real people too. We were trying to respect their experience, right? But overall, it was still overall very well received by the standardized actors themselves. There were no complaints. And then just adding more cases, perhaps including other services like psych or surgery, and in particularly in that case with trauma. And then more equal time for each person to talk in the debrief. So one of the things that we came into this exercise with a list of questions to kind of guide a free-form discussion, and just make it, just see how everything flowed, because we were new to this. Now having a better sense of the topics that people wanted to discuss, we have a better guide on how to debrief. And something to be mindful of is to allow everybody to take turns talking, as opposed to letting a couple of dominant voices take all the time. I think that's pretty much it. In terms of the feedback that we got, in terms of next steps, so we'll go ahead and implement some of these recommendations. We'll try to tailor the didactic portion a bit to be shorter and maybe more interactive, and higher emphasis on the de-escalation techniques, as well as with the debriefing guide. And then in terms of validating this at other institutions, we're planning to conduct at least 2 additional sessions at MGH. We're currently scheduled. It's just a matter of logistics right now. And we're hoping to have a session in August. And lastly, in terms of sharing this curriculum with other institutions. So we want to publish this in academic journals, of course, but we also we would love to make this an open access curriculum that other institutions can just go ahead and implement. And, if they have any questions, they can always reach out to us. But we want this type of work to be taking place in all hospitals in the United States and in all academic medical centers. So we would like to publish this on a website. That's like the best way of sharing this. And, we think it would be a great idea to have the Office of Ideas sort of like host this as like a thing, like as a website, as a sub website, where people can actually access this, download all the materials and all the guides that we have and the clinical scenarios. Provided that they, of course, can acknowledge and give us credit for the work. And we would, of course, love to thank our mentors, Drs. Reagan Marsh and Mike Wilson. And of course, Jay for all her invaluable support and coordinating all the payments and all the reimbursements for all the participants. That was a logistical challenge, but you did it like a champ. Thank you so much, everyone, and to the Office of Ideas for this opportunity.
Great job, you guys. Great job, you guys. I just want to say how commendable this project is. And, being an ICU doc and an ED doc, I am used to everybody being vented or sleep, and that's my comfort space. So, this aspect of it speaks to me because it's probably something I don't pay as much attention to as I should. For you guys, and from my perspective, you guys have created a model that is transcending beyond Brigham. I don't think, while across the campus we're talking about restraints, you guys were already planning and implementing well ahead of what the MGB was doing, and that it's amazingly commendable to you guys, and that you've not only impacting the patients and the colleagues, but you're impacting the C-suite as well in their attention to this work, and really phenomenal.